everybody. Welcome back to the Prehospital Paradigm Podcast. We've got special bonus material here for you. We got a fifth Monday this month, so we decided we wanted to sneak something in and make sure that we were releasing something every Monday, so you didn't forget about us on the following Monday, right? But so five Mondays this week or this month, and and it's also National Stroke Awareness Month, so we figured we'd do a little bit on stroke, and we'll talk about some of the new stuff. And a lot of this stuff, it should have been stuff that has come across in CE, but let's try to can it. Sum it up a little bit rather than the canned lecture, and maybe some more actionable and more field digestible stuff, rather than the very proper slide set that we get in every year in our stroke update. So that being said, we want to talk about the types of strokes first, or do we want to get into, or we want to get into what we can actually accomplish from the EMS side of things with strokes?
I think we talk about the different types first, and that kind of sets us up for the longer discussion of how we manage them. Sure.
So, all right. Well, having said that, of course I hope at this point we know that you've either got an occlusive stroke, an ischemic stroke, where you've got some sort of a thrombus or an embolus that is occluding blood flow, or you've got some sort of bleed, right? You have a hemorrhagic stroke. So, and I think that I don't know off the top of my head what percentage are hemorrhagic strokes.
So in the past, it used to be, and I'm just recalling what we used to use in the slide deck from neurology. I want to say it was like 87% ischemic, and then the other way would be hemorrhagic. But
sounds about right. And that's what you roll.
In the 80s, don't hold me to that number, but somewhat in the 80s for a clot versus a bleed.
I recall it being over 80%. I think as well. So, but we have to treat those you treat those very differently. Our job is still pretty much the same, right? Is
Recognition.
Is identification,
identification.
And appropriate triage, right?
And quick transport.
So
and probably a lot of the history side too that he may not get in the ER. So field history exams.
That's an amazing point. I was thinking about when we decided we were doing this, and I was kind of reflecting on some stuff. Is the longer I go in my career, and then the more I understand how much the story matters. Right? It was, I remember as a young paramedic, it was just, get the tangibles, right? It was, the blood pressure, the pulse ox, the capnography, and now I find myself far, so much more like, tell me what led up to this. Tell me the story, right? How did I get here? Anybody can get all that other stuff. It's
don't necessarily start 2 hours ago. Let's start maybe a week ago, or maybe even 2 weeks ago, and whatever we can bring to the table to assist you guys, and passing on that torch and making sure the continuum of care happens appropriately is definitely warranted.
Right, yeah, that subtle thing that somebody mentions, like, well, yeah, a couple of days ago I had this dizzy spell, or I had this or that. It's like, I can remember a time in my young paramedic mind, I was just like, whatever, I'm here for this thing now, right?
And now it's almost like a light switch.
And now it's like, ooh, tell me more about that. And then was there anything else like that, right? And it's actually fun to, at this point for me anyway, to what's the whole picture here? You can really make more of the a crisper diagnosis, field diagnosis, or differential diagnosis when you have that story. So, Caleb, to your point, you're absolutely right.
Well, that's what medicine used to be, right?
Right.
Right now, it's 2023. We've got CT machines, MRI, ultrasound, quick, rapid blood tests.
Yep.
50, 60, 100 years ago, we didn't have all that. It was history, physical exam. That's all you had.
History, physical. Yep. It was all touch and feel, right?
Yep.
It was you're flying the plane, stick and rudder, right?
Yep.
It was.
And right now, that's really what medicine is from the doctor's perspective. Is I go on history and physical. That sets up in my mind what I'm looking for, what I need to rule out as the really bad, terrible things, and I have now my test to verify that. But if someone had a terrible hemorrhagic stroke and they weren't breathing so well, and I intubated them, and I heard the story of this happened all at once, and they're ignoring one side of their body, oh, this is a hemorrhagic stroke.
Yep.
That's what this is. The CAT scan's only just going to prove me right.
Correct. You're just using that to validate, essentially what you already know, right? Yeah. So now, having you talked a little bit about the hemorrhagic. Let's talk about ways for us in the field to differentiate. So we can kind of get the correct mindset of, hey, do we think this is a bleed, or do we think this is what kind of things are gonna kind of lead us to a hemorrhagic versus an ischemic stroke?
So I'm going to bring in trauma a little bit too. That if there's blunt head trauma, that's still hemorrhagic intracranial bleed, right? Which is what a stroke is. It's just whether the bleed was caused from hypertension, from medical cause, or a traumatic cause, right? So acute onset, if there was head trauma, headaches are a big indicator of intracranial hemorrhage, especially if we're talking about like the worst headache of your life. Quick in onset and then gets better, or it's worse at onset and then will slowly get better afterwards. That we think of being an intracranial hemorrhage. Really bad looking people like low GCS, if they're have posturing going on, if they're neglecting one side, if they're not breathing so well, those could be signs of both. But we're really going to more worry about the hemorrhagic shock. I'm sorry, the hemorrhagic, the brain bleed, because that is the patient I'm not going to give the thrombolytics to and have to go down a different road and have to worry about, when we're talking about getting the full picture from the patients and the families, to like know what medications are on. Are they on a thrombolytic? Are they on antiplatelet medication? Because those are all things that I have to reverse in the emergency department when you bring them to
And
me.
not only knowing, are they on them, knowing, did they stop taking them? Were you able to get your prescription filled? How many have you taken? I can recall a call recently where it was, I'm on blood thinners, and they fell and it was a possible head injury, but we hadn't taken the blood thinners and it's been a month now. But, well, why? And that really doesn't matter to me, but I need to bring it to you and say, listen, yeah, they are on blood thinners, but they haven't had that blood thinner in a month.
Yep.
So,
and when they took that blood pressure is going to change, or the blood thinner is going to change how we manage them, especially if it's a 12-hour medication that they take every 12 hours. Well, it's been over 12 hours since I took it, versus 24-hour medication, versus if it's warfarin, whether it's one of the new type of anticoagulants. The novels, the novel oral anticoagulants. And we manage those differently. We give them different medications to reverse that.
That brings up a little subtextual point there, is be specific, not just, hey, I'm on a blood thinner, or I'm on an antiplatelet. Your course of care changes based on
what it is,
the duration of action of that medication.
And it's funny because most seasoned medics, if you've been doing this long enough, if somebody tells you you're on the blood thinner, for some reason they automatically will say, hey, doc, they're on Coumadin.
Correct.
They're on warfarin.
It's
and it's
default,
like,
It's just common, but now there's so many new ones, Eliquis, all these different, all these different names. So it's like we should ask more questions. Which blood thinner which blood thinner is it? How many milligrams are you on? How many times a day do you take it? I mean, easy thing for EMS is great. We'll just take the bottle with us, right? So it's just,
and also
and
we get
take a picture of it.
Yeah.
Hey, doc, this is what they're on.
100%.
Perfect.
we get such a habit of typing in our iPad to say, they're on this medication. Well, it didn't pop up. And part of the problem is we have the ability, and each department has the ability even to add medications to the list. Do it, research it and have it red flag it to say that this is a thinner, it's an anticoagulant, something like heparin and warfarin does. But we're not going to catch them every day on the EMS Institute side. So if you see it, you can let John Cameron know, let one of us know, and we'll make sure it gets added to the list.
Your EMS coordinator should be able to.
Absolutely.
They certainly have that privilege in health EMS
to add these.
Hopefully they have the technical wherewithal. If not, they have the resource in
Correct.
UH to update that.
Yeah.
But don't rely on it. Is basically, it's a great asset. It's a great tool. It's a great, CYA. But at the same time, let's make sure that we're not strictly relying on that to know that that's a blood thinner.
The other, another point there is, you're likely to see that patient again, right?
Yeah.
I mean, if let's face it,
Absolutely,
a fair amount of our patients, once they get to the point where they need us once, they often need us a couple more times, right? And so, in my service, we cover a very large area, and we'll see pockets of medications being used or what's prevalent in that area because they all have the same cardiologist, or the same PCP, or the same neurologist. So you'll see
clusters. Usually have a couple physicians that'll round. So
exactly. So it's almost it's almost peel and stick. It's just everybody's on the same thing. So it's worth the time to report those if they're not coming up in your charting, because you're likely going to come across it again.
100%.
And it's funny, too. I mean, taking that one step further, and it's kind of off topic, but when you go to hospitals, they say, oh, today's been GI day. Well, there's a reason for that.
Yeah.
We're pulling from the same population here, and that's probably why today is GI day. So it's not just a coincidence.
Right.
But
And to your point, and we talk a lot about what you guys do in the field and helps us in the hospital, the emergency department, but it also depends upon how and where you're possibly going to transport that patient, right? So a fall on a blood thinner, you're going to make sure you take to a trauma center as opposed to a patient that is exhibiting stroke-like symptoms, not on a blood thinner, they can go to a different hospital. Or if they have certain signs and during your exam you find concern for a large vessel occlusion, that's going to determine where you're going to transport this patient as long as it makes sense for the situation.
And speaking to kind of a multi-systems trauma, because it's kind of trauma time too that we're talking about, can we have multi-system strokes where it might be a stroke and an MI?
Or stroke and a trauma.
Yeah.
Of course.
And one might lead to the other.
Right, and that goes back to the story, right? Before you crashed your car, what was going on, right?
Exactly.
Yeah.
So erring on the side of a trauma center isn't a bad idea anyways. But again, the story of what we can bring to you, it makes all the difference.
Yeah, absolutely.
And at least in our area, obviously there's, larger population this is going out to, but, certainly Northeast Ohio, most of our trauma centers, our level 2s, our level 1s are also very capable from a stroke perspective, right?
Yes.
So you're not losing anything by, getting them to, at least, again, in this area. Now, is there some place that I'm sure there's a great trauma center that doesn't, that doesn't have appropriate stroke, or not say appropriate, as high of a stroke certificate? I'm sure it exists, right? But
Most of your places that are going to be comprehensive stroke centers here in Ohio are going to be your higher level of care for traumas, and or they're going to be your quaternary care centers that have all of the specialty services there. So sometimes that might be the better choice for a patient, depending on where you're at.
Absolutely. So you touched on, I think, the real piece, the triage piece. You started down this already, and that's 2021, December 2021 changed, at least in Ohio, how we were mandated to change how we do business, right? And before that, we were doing, I remember early in my career, Cincinnati, stroke scale, and then we're like, well, we're not identifying enough.
We're not looking at large vessels either.
We weren't identifying enough of, other types of strokes. So in this area, we got Mend out in the world. And then in December 21, the state of Ohio said, basically, you need to act like these are cerebral trauma patients, right? Yep. And you need to get them to, to acute care centers specific for. And that legislation that on the trauma side of things already existed in the state of Ohio. We're mandated to take them to trauma centers, and basically, I don't say it was a mirror image, but it's very similar in concept and construct.
Oh yeah,
was mandated upon us in 2021, and that what they want us to look for is, does this patient have a large vessel occlusion, and do they need that? Do they need that comprehensive center, right?
Correct.
So that changed. That kind of changed the way we did business as far as the assessment tool. And
now, I mean, we didn't have anything formal before that. If we look at, yes, we have protocols that are approved by the state, your medical director, and realistically, in the past, trauma was the only thing that controlled law. Like you shall, right? Not should or could or can. It's you shall
absolutely
transport a trauma patient to a trauma center. And I know they have 5 exceptions, but stroke really started to mimic that now. The state really wanted every agency to nail down a stroke protocol that's approved by your medical director, submit it to the state, and then now we have options. So just like trauma centers, we have, I would say familiar in our area, we have level 3s and we have, level 1s downtown, or you want to talk about a larger system that serves a region, same concept. So we have all these community hospitals, if you will. So, Geauga and Portage, we have primary stroke centers, and then, Cleveland Medical Center is going to be our comprehensive. So we have that, once again, that larger hospital in Cleveland that's going to serve this base as the comprehensive. So maybe it'd be good to move into the different types of centers first, then we'll double back to EMS. So if we talk about the differences between stroke centers, we have, stroke ready centers is essentially your level 4 trauma center, right? They can bring you in, they can perform a CAT scan, they can look and see if we need to, give this patient a TPA. And I think we could kind of double back to the CAT scan. Is we were talking before the show is, what are we looking for on that CAT scan? We're really just looking for bleeding, right? I'm not trying to confirm they had a stroke on a CAT scan. I just want to see, do I see white, and is this a hemorrhagic stroke or is it a clot? So we start to look at what type of stroke they're having, and back to the centers, we have stroke ready. They're essentially going to take care of that patient for a short period of time and then transfer them.
Yep. Goals have them out in 3 hours, and you have telestroke to kind of help guide the care of those patients.
Yes, and UH Neurology has contracts with even some non-UH hospitals that serves on the telehealth, for lack of a better word, on that platform. Then we move up to a primary, so I'll use Geauga since it's right down the road. They're going to be a primary stroke center. They're going to be able to do the CAT scan, make the determination, determine if TPA is appropriate for the patient, or TNK now, right? We'll have to cross that bridge in a little bit.
Somebody literally just typed that.
It just clicked when I was like, "Oh yeah, no more TPA."
He's chuckling because he's watching me populate the show notes.
So that's why we say thrombolytics. We don't just name TPA, TNK.
Yeah. You're showing your age, man.
My bad.
You're showing your age, right?
But either way, we get to the thrombolytic choice.
There it is.
Primarily TNK. But now these days, since I've come up to speed, but that patient could be administered TNK or a thrombolytic, and then if they start to improve, a lot of times we still have the telehealth option in a community hospital. And if that patient's NIH starts to decrease, then we could admit them and keep them in the community.
Yep, and your primary stroke centers are the largest in number in the state of Ohio. We have 57 as of recording of this show. Your stroke ready, as you said, we have 17, and those are hospitals that can receive those patients initially, start the care, but
identify the stroke.
Start those the thrombolytics if necessary, but it will likely be transferred out. Your primary stroke centers that all of the community hospitals are, we can accept them. We can give the thrombolytics, and we'll keep them there as long as they're appropriate and stable to stay there, and they don't need any higher level of care.
Yes. Yeah, then we get into the factor of a thrombectomy capable hospital. And then obviously at the highest point we have a comprehensive, right? So the end all, the be all, the mecca of stroke care is going to happen there, neurosurgery suites, and essentially all the resources in-house that you're going to need. But let's flip back a little bit. We're going to talk about strokes, and maybe I'm going to sidebar here just because I like talking about this. But
before you do, is he in and out in your headset?
A little bit.
A little bit? Just rotate that up.
I don't know if it's clipping or.
What about now? If I change my voice, it sounds real nice.
So much.
You guys are all staring at me. It's really weird. It's hot in here. All right.
It's not hot in here.
I'm fine.
I'm fine.
I'm fluffy. I'm talking about strokes. I'm talking about bacon. Am I talking too much or no? Are we going off that? I think we talk about the centers. I think we talk about the different centers. So we loop back to what we're going to do.
Yeah, absolutely.
Whatever.
All right, so back to thrombectomy capable versus a comprehensive, and some of the imaging that's going to be done when that patient arrives at the hospital, and that decision might be made whether or not are we going to treat this patient in whatever level stroke center that's available to you in your region out there. But another thing that we can also do as a follow-up, you'll hear us talk about, we're going to get a CAT scan, a non-contrast head CT immediately. We want to check for bleeding. And then we could also follow it up with, if I don't see any blood, I could follow it up with a CTA.
Correct.
Right? And that's going to tell me where that clot is located. So if that clot is located in a large vessel, which is what the state of Ohio wanted protocols for, and we'll get into the VAN exam later to make that decision, now is that patient going to be better served in either a thrombectomy capable hospital or a comprehensive, right? Are we going to go get that clot, retrieve it, remove it, and that's what's going to be best for that patient? Or, maybe it's in a smaller vessel. So a lot of times I think EMS providers are going down all these different pathways thinking, different centers we have to transport to. Is it a clot or a bleed? Right. Because we don't want to see these patients get transferred, right? That's hard on them. That's hard on their family. Financial costs. We want to get them to the right place at the, in a right amount of time.
Exactly. You don't want to take them to one emergency department, just have them dwell there when you guys could have taken them to the most appropriate center.
100%. Yeah. We want to try to deliver them to definitive care. Right? Yeah, 100%.
You don't want to delay that care either. And none of us have crystal balls. We can't just magically look at a patient. I know exactly what's going on, but I can use my history. I can use my physical. I can use what I see to determine what's going to be best for this patient.
One of the biggest changes in the way that I've been teaching the paramedic class, and Scott can relate, is that we're teaching that, what is our end goal when we get 911 called and we respond? It's to take the patient from where they were before the incident and put them back in that same capability. That would be, as a whole in the system, our goal for any patient. And I think to add to a comprehensive center, then it would be rehabilitation center. Correct. And my mom had a hemorrhagic stroke 4 years ago now, and one of the biggest parts of that was rehabilitation. And so getting them to the appropriate facility so that they can get everything under control, and then making your way through all the steps to finally get there. And, finally getting home is huge. So,
no, I agree. That's a huge component, Caleb, that you bring up is, we always see the patient in EMS as, this is how you present, and we do our job, and we take them to the emergency room, and then we give them to John, and then that's it, right? I hate to say it that way, but that's true, right? How often are you going to reconnect with that patient? So we don't see the aftermath piece. You don't see maybe speech therapy or physical therapy, rehab. We don't see how does that patient go home?
Right, and that doesn't happen overnight. You're talking years to months.
Yes. Yeah. That's a long road to haul, and just the resources at those facilities are just going to be, better for that patient overall.
Right, and I think looking back at our finest for the EMS side of things and emergency care, how can we best get the patient there? And that's going to be our pre-hospital management. And as I've said before, I think history is huge to pass on and say, Doc, this is what I saw. But I also think that we can do things that could hurt the patient as well, and we want to avoid that. I mean, are we going to be treating hypertension?
No.
And why are we hypertensive with a stroke?
Hypertension is actually necessary in this patient.
Correct.
Right?
So I've heard rumor, and I've been told before by older people, we have drugs in our box that will lower the blood pressure. Can we give them a nitro or something? And well, maybe it's not in the protocol, but if I make it a sidetrack here, we don't want to do that. And I would love to hear your explanation as to why, because.
So hypertension in strokes is more of a confirmatory thing. Like, again, we have our history, we have a physical, this looks like a stroke. And I look at the blood pressure, they're hypertensive. It makes me think that this really is a stroke. And the reason for that is your brain is very good and smart, and your body is very good and smart. And it knows it has a blockage, and it knows I got to get blood to somewhere that's not getting blood. How am I going to do that? I want to increase my pressure to help push blood past that clot to try to get blood to where I need to be. So in our world, there are certain guidelines we have that we actually don't even want to lower their blood pressure. We actually, if we're not giving thrombolytics, we're not going to lower their blood pressure. We're going to allow permissive hypertension. If we are giving thrombolytics, we are going to lower their blood pressure, but that's only for a safety concern, that we're giving you a medication that's going to break down those clots. And because I know I've got some tissue damage behind that, you have a risk of bleeding. If I increase your blood pressure, that risk goes up. If I lower that blood pressure to a safer area, to a safer zone, I decrease your likelihood of having a bad hemorrhagic conversion after getting that thrombolytic. So that's why we don't treat the hypertension.
Yeah, no, and that's great to hear, because I think that's a very important side of it. The other important sides is differential diagnoses, and being able to understand that there are so many factors that can play into a change in mental status or stroke-like symptoms, and I think that we need to be capable of ruling those out to get to you, so that we're not reinventing the wheel on his end. We can say, hey, doc, glucose was fine.
Correct.
You know, hey, doc, the blood pressure was so-and-so. You know, the van was this, Cincinnati was this. So we're not delaying. We want to get to, where they need to be. And if we're delaying, and if he's repeating things because we didn't do it, that's a problem.
Probably one of the more QA'd things, for my providers is situations where there was just lethargy and they want to just basically rule out, they just basically ignore stroke. Well, it's because they're not eating or drinking. Well, it might be part of a much bigger picture, right? And, often it's, hey, you also should have done a stroke screen on it. What would it have hurt, right?
What would it hurt?
Right. What's a pre-hospital stroke screen on somebody going to do? Doesn't hurt.
Like a blood sugar.
Doesn't take much time, right? So it's a tool that you can empirically apply in all of your altered mental cases. Like clearly, if blood sugar comes back 33, but is that the only problem? I certainly been on many cases where it's like, oh, surprise. Now they're after an AMPA D50 or whatever. They're you got
they're 230 and still struggling.
230 blood sugar, but they're not waking.
But we've rolled out something on our differential diagnosis,
correct.
And that's kind of the point. And the same can be said. I think we've talked before about STEMIs and somebody who might be having chest pain. Well, did you look at the skin? Did you look for, is there something else there? Is it cardiac all the time? No. And the same can be said for strokes.
Yeah.
Making your patient fit your treatments is also, I heard what you threw in there, right? And I certainly know of situations similar to that, right? Where I have a thing, I can do a thing, so I'm looking for reasons to do a thing, right? Exclusive of its clinical appropriateness, right? And certainly in a case with a stroke, right? Yeah, you can treat blood pressure. You've got several agents. Some even, I don't want to use the term volatile, but with a heavier lift than the nitroglycerin available to us in our box, and that is damaging to these patients, right? And just to reiterate what you said, yeah, you modify blood pressure on the hospital side of things. That doesn't necessarily make it okay for us, but then you're immediately following up with corrective treatment for said clot, right? We're not doing that piece, right? So we can't put the cart before the horse, right? You're going to modify that blood pressure, then immediately work towards correcting, said occlusion, right?
Correct.
And the other thing with that too, that back to Caleb's point, when we talk about hypertension and we don't want to lower the blood pressure, we do not want to treat that, and we have that elevated blood pressure. I'm gonna it's coming. I'm gonna say the magic word here in about 2 seconds. So why don't we want to do that? Because we want to save the penumbra.
There it is, the penumbra.
The penumbra.
Hey Ray, what's the penumbra?
So I describe this in my own words. So the penumbra is the part of the brain where let's just use obviously an occlusive stroke, and that part of the brain is receiving less blood flow, right? So we get increased hypertension, trying to perfuse and send oxygenated blood to that portion of the brain that is essentially I call it limbo, right? So that's the portion that could either die, or we might be able to salvage that as those neurons are essentially dying, but it's still receiving some oxygenated blood. It's in limbo. Yeah. So that's what I call the penumbra. It's the brain that's in limbo that we could possibly save. So if we lowered that blood pressure, and now that portion of the brain doesn't receive blood,
it's hypoperfused.
And then we get tissue death
and everything else.
Yeah, and we're just making it worse.
Which also brings up the next course of care, which is appropriate, would be oxygenating my patient. And anybody under about 94%, we're going to want to make sure that we bring them back up. We need every bit of your blood to carry oxygen. That's there. So
And more is better here, right?
More is better.
You're right. Yeah, we should just turn the knob
Free
until
radicals?
We should just turn the knob until it stops, right? We've clearly I'm being sarcastic here. We've gotten away from that, and Dr. Hill, where do we kind of want these? What from the oxygenation perspective? Where do we want them to live? I mean, why isn't 101% better?
and not to sidetrack, but we've talked about this before. You bring up a great point. We don't stop at 100% oxygenation. We go past 100%. You could oxygenate somebody much past
the
it.
PaO2, right? But our machine stops at triple
Stops
digit.
at 100.
Yes. So ideally, we want them 95 to 100. Really 95 to 99, because if you get 100, again, you can't read above 100, so we don't know what we're doing. So somewhere in that range is fine. Whether that takes no O's, whether it takes 1 liter nasal cannula to needle, that's all you need. And honestly, if you're going above 4, 5, 6, look at other things you should probably do, and CPAP would be a great answer to that question with not a breather.
Can I
your
see
airway
a
pressure
stroke patient?
Yeah, absolutely.
There's a great lecture
I'm about
on
to say,
CPAP. somebody
wouldn't it be
did.
nice if there was a talk about CPAP out there that people could go back and refer to? And we didn't specifically put that in the show notes. So, but back to that. I mean, if you require high oxygen demand on a stroke patient, something else is going on, right?
Correct.
And there should. You've got a pulmonary problem, or
you've got a really bad bleed or a really bad stroke going on that you need to intervene in.
sure. Then the patient maybe is bradypneic because it's pontoneal occlusion or bleed or something like that. And they're bradypneic and they're barely ventilating, thus that pulse ox. So that should be a clue if you have a high FiO2 demand, a percentage oxygen demand, to make 94 to 99%. That doesn't scan, right? There's something else going on.
Yep.
So how is your ideas on hypotension and strokes?
So hypertension is super bad, right? So we're talking about making sure if the brain's having a stroke, essentially a MI of the brain, right? We have a blockage. We're not getting enough oxygen and blood to the part of the brain. Hypotension is going to make it way worse. So now we're hypoperfusing the whole brain and causing really bad things to happen. So that definitely needs to be fixed. And we're going to be shooting for a very normal blood pressure in these patients. Systolic is greater than 90. But obviously, if you can get 100, that's better. 120 is better. Because again, we'd expect these patients, if they're having a stroke, to be hypertensive.
And this isn't something I probably want to throw push dose epi at. Maybe saline boluses.
Saline boluses would be good, and about 500 ml aliquots would be appropriate. For most people, though, you're going to start an IV, you're going to start your fluids, you're going to run those wide open, you're going to bring them to us. By the time they get to us, you're going to be in that range of 200 to 500 based upon how good your IV is, how big an IV, transport time, all those things. And just so we're kind of clear, I worry about blood pressures with systolics that are above 220. So, I mean, these are very high blood pressures. So when I walk into a stroke patient's room and I look at the monitor, I'm like, oh, their systolic blood pressure's 210. Yep, that absolutely fits. So I'm expecting to see very, very high blood pressures in these patients.
When would be your most wanted time from EMS to contact you when we suspect strokes? Right away?
Yes. So I would say anything that is going to be a critical care patient for us, whether that's you're intubating in the field, you've got a trauma, you've got a STEMI, where you want more resources to be available in the emergency department. The earlier you call me, the earlier I can get those resources available. Most people don't have actually the luxury to transport to a level 1 trauma center or even a comprehensive stroke center. Yeah. They're going to be going to their local community emergency department and community hospital, and all of those resources that you might need at 2 o'clock in the morning aren't going to be readily available, let alone sometimes even at 7 o'clock at night. So the sooner you call, the sooner you get my mobilization of my resources to get going. And one of the reasons for that is you call me with a stroke alert, I'm going to clear a CAT scan for you guys. I'm going to hold a CAT scanner open not take anyone over there until that patient arrives. Because ideally, in the ideal world, it's, hi, I'm Dr. Hill. What's going on? Let's walk and talk. Let's go to the CAT scanner. I'm doing my neuro assessment as we're loading him from your cot onto my CAT scanner table. I'm doing a quick assessment so I know left side, right side, how bad it is, and we're going to push him into the CAT scanner and get rolling with the assessment.
So I think that it's fair to say that time is brain.
Time is brain.
And we should also be limiting our time on seeing.
Yes.
Very much so. To about 15 minutes or less.
But before we have that, just for absolute clarity on, I think on what you were suggesting is, even if that's 2 phone calls to your sending, it's like, hey, we're likely working a stroke. We're extricating him from the house. We'll call you en route, right?
Yep.
Yes.
That extra time, I think there's
I think there's a lot of weight in that.
Well, there's certainly weight in it, but I think there's a hesitance from the provider to
be wrong.
Not necessarily be wrong.
I think that
but
we're worried about being wrong, though, to call.
Incomplete information is where I was going with it, but there's probably a point to to that as well. Is you want to do a second? Some providers might want to do a second assessment to be absolutely sure before they call it, right? I think that's an absolutely fair point.
Yeah.
I was, a reticence to give incomplete, because inevitably whoever's in there have found, do you have a blood pressure? Do you have this? Do you have that? You might not, right? But it's walking, talking, quacking like a duck. It's likely a duck. You would prefer to know ahead of time, and I think most hospitals would prefer to know ahead of time, and then be like, yeah, here's what we have. Looks like stroke, or this is clearly a trauma, right? I gave you the details later, right?
Yeah, I want to know early, but I want to know not necessarily I'm going to be Goldilocks here. I want to know a little bit more than all of it, and I don't want to know the bare minimum. I have concern for a stroke. We can say if it's a terrible stroke with deficits, hemodynamically stable, those types of things. Versus trauma too. Like I'm going to be bringing you in hemodynamically unstable trauma is different than I'm going to bring you a trauma. I'll give you a report in a few hours or a few minutes. When
few hours. Oh, wow, that's a hell of a transport time.
Yeah.
If they're getting transported by horse and buggy, possibly.
Very much so.
But they don't call either.
I think what Scott's saying, I think that's a big thing, and I think we really shifted that thought process with STEMIs a lot. You walk in, you start talking to your patient, you're getting that impression. Somebody else is obtaining the 12 lead, it prints out, we transmit it, and then we gave that really quick call. Hey, I sent you my EKG. That is a STEMI. You need to look at it. I'll call you back, but I'm giving you a heads up. We're coming to you, right? And that's a benefit.
Love that.
That's a benefit for you, and it's cut and dry. So I think doing that with a stroke and having some of the information, like I have, left-sided arm drift, the patient's, nonverbal, no traumas involved, their blood sugar is this. I'm just giving you a heads up. Hey, we're bringing you a stroke. I'll call you back with more information.
With full details,
Yeah, with more details. I think that quick heads up is beneficial.
It is, and what a lot of emergency departments, at least in the last few years since the big wave of COVID came and no one went to the hospital, now we're post-COVID back to really busy hospitals, understaffed, overcrowded. I might not have a bed available for you right now. So if you give me an extra 5 minutes, that's 5 extra minutes. I can maybe
That's actionable time.
move a patient out, prep a room for you, make sure CT is going to be cleared, and that way we can get you offloaded quicker.
No, leave them out in the waiting room.
Well, and that activates other people too, right? Because that's going to activate registration.
Yep.
So as you're talking to the patient, registration's right there. Hey, what's the name, birthday, social, verify this as we're walking, because they have to put that into the computer because you're going to order a stat head CT non-contrast, scan for that patient. And I do agree with your point too, is it's unorthodox from our past, right? It was like when you call, you have to have A to Z. I can't call and only give you about 3 things over, maybe 30 seconds time and then say, I'll call you back. Yeah. That just wasn't heard of in the past. Right. Now we're so proactive on early activation. Give me some tidbits of information. I know what I have coming in, or I could call you and say, I have an unresponsive patient that is decorticate posturing, and we're preparing to intubate this patient because they're not oxygenating appropriately. Heads up.
Yep.
I'll call you back.
Yeah.
Right.
We have work to do. I'll call you back.
I know I need a room. I want respiratory therapy down here. I want all my help. for this sick patient that's coming, that I want all these resources that you guys are bringing me. And again, 5 minutes makes a huge difference.
Yeah. And if we get them out to the truck and during transport, like,
maybe things get better.
oh shit, they're just hypoglycemic. All right, here's some D10, and they wake up, and you can call back and be like,
that goes back to, I think Ray can definitely relate on the fire side, that we have automatic mutual aid, and I would rather cancel people on the side of caution than call later.
Correct.
So being ahead of the game, I'd rather call the hospital back and say, hey, listen, we erred on the side of caution. It was the glucose, but we fixed him.
That's the best news I can hear.
Right.
Yeah.
I'll go back to my
complain about
30
that.
in the waiting room.
Right. It's like, okay,
Which brings kind of the next point, that when we do get a chance and we've called you and maybe we've activated the stroke alert, what additional vital signs should we be providing to give you a better glimpse in the squad?
I won't just say vital signs. I'll say there's certain key information that we've talked about. Blood thinners, anticoagulant use, when that was last taken. Last known well is the big one, right?
Yep.
We need to know when that person was last seen normal.
And not when the patient says they were last known
correct. Well, they woke up like this, or no, I get up at 4 o'clock every morning. I go pee. I was totally normal there. And then I made myself breakfast. And then someone else comes down and sees the patient and finds them at even an hour later. Well, I know you woke up at 4 and you were normal at that time. I've got a short time period. I have the ability to possibly give them a thrombolytic versus no. I couldn't arouse them in the morning. And we finally got them up. The right side of their face was drooping, and that's a true wake-up stroke, and we have to go based upon their last known well is going to be the time they went to bed last night. So we don't know in that time frame overnight when this occurred. We are going to be conservative from the standpoint of it's when they were normal, when they went to bed, because I don't want to give this thrombolytic and then cause a massive bleed,
right.
which is only going to make the stroke worse. Blood around the brain is different than in the vessels, and they're going to the parts that they're supposed to be going to.
So weird.
I know.
So weird. The brain is a funny thing.
Yep. So we last known well, glucose. We want to know Cincinnati, so whether they're screening positive for stroke, and then whether they're VAN positive, which we'll talk about. Essentially, that large vessel occlusion assessment, that we're concerned for that, because if they are, we're going to want to make sure we've got a large bore IV and an AC that we can actually push contrast through to look at the large vessels of the head and the neck.
Now, you got some notes in here about the different arteries, just kind of a little step back to
back to
physiology.
anatomy and physiology.
To the ICA and the MCA
So large vessel occlusions are in 3 different vessels, and they account for about 25% of the strokes. So we're worried about the internal carotid artery. We've got the middle cerebral artery. We have got 2 segments that we worry about that. They're going to be the most narrow segments where we can get to. And then basilar artery as well. Could, I guess, technically be the anterior cerebral artery as well, but more than likely the most common place is going to be your middle cerebral artery, and that kind of does the side of your head and does the extremities, and its left side is going to be speech, those types of things.
And I don't remember which one of you guys touched on it, but when maybe you said that clearly, but just to restate it, what are you looking for when we put them in the scanner, right? Because I think there's this misconception of you can see a stroke.
Correct.
On a non-contrast.
On the non-contrast CAT scan, I'm actually looking for a normal-looking brain. Right. I want it to be a normal-looking brain.
You want it to be negative.
I want it to be a negative, and that's the call I get. I get a call from radiology. Hey, this is Dr. Radiology calling your stroke alert, normal head CT. Perfect. That's what I want to know.
Now a candidate for TPA.
Now they're a candidate for TPA.
Because there's no bleeding.
Correct. There's no bleeding. And at that point, the ER doc's already looked at it. If you've got neurology on call and you're doing that whole neurology team in the emergency department, they're going to look at it. And then the radiologist is also overreading it. So you're going to have 2 to 3 sets of eyes looking at that, because in that case, for my last stroke, we were mixing the TNK, and I was waiting for my confirmatory call from radiology to say that I didn't miss that bleed. So
But you were already ready to go.
yeah, we were already ready to
based
go.
on essentially physical exam.
Yep.
Yeah, and then you touched, you brought up the TPA versus the tenecteplase or the TNKs. Why the switch to that, and what's just so the providers know? I mean, the TPA was the gold standard for the longest time,
And it still is.
Yeah.
TNK, the reason why we switched to it, when you're doing TPA, you have to do a bolus, then plus a drip.
Yeah.
There's a little bit of complications with doing the drip and making sure you're flushing the line and making sure they're getting the right amount of dose.
Technically difficult.
Technically difficult. When you're dealing with drip sets and calculating how much drug is going to be in that drip set and then how long you're going to run it over, all those things. And that's on top of the push they got before it. Tenecteplase makes that much easier. Yeah. Now it's just a single push. Right. So no calculating, no drip sets. It's a single push. Yes. Yeah. And at least anecdotally, we've seen decreases in our time to medications. Time to thrombolytics have gone down at my shop because of it.
And arguably safer because there's less room for error.
Yeah.
Yeah, and any decreased time we can have, back to Caleb's point, obviously it starts with recognition, right, from the patient or their family member. They call 911, we show up, we do our assessment. We want to decrease our scene time, get them to the facility as soon as possible. We want to fast order CT. Hopefully we get a negative, a negative reading. We don't have any bleeding. And then we want to decrease order needle overall, right? Because then we have a better likelihood of that clot dissolving and, that part of the brain being perfused again. So it's just, how can we speed this process up?
So we know our on-scene time for EMS should be under 15 minutes. What are your goals for the hospital?
So our goal for you actually is less than 15 minutes. Quicker is going to be better, obviously. The goal for us is straight to CT, as we talked about, and most of us will just walk and talk with you guys as we go back. Officially, our UH standard is door to doc times less than 10 minutes. I can tell you that we're there on arrival for stroke alerts.
Sure.
Because we know they're serious. Door to neuro expertise is 15. For most of the community centers, we're calling. I'm calling to talk to a stroke neurologist as I'm in the CAT scanner, just to start that, so they get the call back, and they can look at the CAT scan. I can look at the CAT scan, or radiology can look at the CAT scan. And then our goal is our door to thrombolytic is 30 minutes with inside UH to try to meet that goal, which I'll be honest, it's hard to do. It's hard to get a patient from the door, get them registered onto a CAT scanner. I have to do my assessment. If we're going to do both a non-con and contrasted scan, that takes time to hook up the contrast, time out the bolus, have it do, scan, have us look at it, take the patient off the CAT scanner, put them onto a hospital bed, weigh the patient, because all the thrombolytics are weight-based, get them back into a room, get them hooked up, draw our bloods from them, get them on the monitor. I have to make all these phone calls, so I have to wait for radiology to call me. I have to call neurology, talk to neurology, then collectively with the patient make that decision of you're either inclusive for getting a thrombolytic. These are the risks and benefits of doing this. The big benefit being that you have an increased risk of bleeding, and this is what your risk is. The benefit being that we could possibly reduce your stroke symptoms and give you a better outcome with this. But this is what choose right now, right?
Right.
And then once they agree, and it's even worse, I've got to manage blood pressure, and then now I'm giving them medications to drive their blood pressure down to the appropriate goals that I can give that thrombolytic to then decrease their risk of having that bleed. It does take some time to do. Yeah. It takes a lot of man hours to be on it and quick, and that's why we want the early phone call so we can organize our team to help treat that patient.
All right. Without getting on my own personal soapbox here, you did say one thing, and that was draw your labs. Is there any advantage if the EMS service comes in with the labs pre-drawn for you?
For us, yes.
In that particular case,
we're gonna take those labs.
Yeah. So
that's hospital dependent. Some hospitals don't like those labs drawn pre-hospital, but for us, we'll take them.
Sure.
Yeah, that proved beneficial. when I was there, and we really pushed that for EMS to do that and draw those labs pre-hospitally. I mean, we were saving between 10 to 20 minutes because it's just another step, drawing the bloods, labeling the bloods, and then sending them down versus, hey, I did this, and now we're just labeling.
But it's definitely important you get the correct labs. You can't come to the ER with 3 red and black top tubes and expect them to be able to run a PTINR on it. So, and if you're going to draw the blue tube, which is one of the most important in this case, it needs to be drawn to the black mark that's on the tube, or else it's no good either. So, there are some other aspects to that, and we are more than happy to walk through those with anybody that wants to know, especially during our con eds and all that, and we'll make sure that it gets done right. The tubes. Not to get too sidetracked, but I mean, there's EDT solutions and some of them that have like almost a heparin basically, and you have to be very careful in what order they could be drawn and what tubes are being given. So
yeah, that was going to be my big point here. It's just, I get this bag. Does it matter what order I draw on? Stuff like that. It does matter. There's a reason and a methodology for it, and I think
the marks on the tubes matter too. You have to hit those marks, or they're no good.
So if you're one of those departments that has them on the truck but may not do it, this is a case where you literally can be saving brain, and this might be this might be the case.
And so ideally, we don't want to poke a patient at a separate another time to cause another poke through the skin.
Potential bleeding site. Yep.
Like, especially if I'm getting TNK.
Right.
Although they're going to need 2 IVs anyways. What we're going to do is we're going to use the squad IV. So you've already flushed that with the saline. So now I've got to take your squad IV. I've got to do a waste container and pull one out. Hopefully I'm going to get drawn blood back. If not, I got to fiddle with the IV to make sure I can get blood to come back on it. But I got to do a waste container, then draw my lab, then reflush your IV. If you guys
hope that you don't have hemodiluted blood and the lab calls you.
Yes.
Yeah.
Or hemolyzed or all the other issues that labs had come up with.
Back in the day, there was a push larger bore IVs with the TNKs. Is that still as necessary, or are there other factors for the need for larger size IVs in these patients?
There's other need for it, especially if we're going to be doing.
Did I pretend to? Well enough on that. Okay.
Present.
For CTA purposes, I need a larger bore IV in a proximal vessel, so it's going to be AC or above, to give that medication quick enough so it doesn't blow, because I need to see it in a timed fashion to go in the arteries of the neck and the head to look at it.
Those infusers press that in pretty fast.
Yes,
and that is why we ask for 20s, 18s, or at least, right?
Yep. A trauma surgeon once told me that every trauma patient should get two IVs with the total gauge being 20. That's an appropriate IV for a trauma patient.
I like that. So a question that I've heard before: can you give your TPA, TNK, IO?
I don't know.
Neither do I.
Okay. I will find that out.
Yeah.
Probably not. I'd probably say you probably can. I don't see why you couldn't, because honestly, most IOs are like central lines, especially humeral heads. They're just right there by the blood
supply. They're wonderful.
They are fantastic.
There's great videos on Arrow website if you go and watch and how fast you can. It's amazing.
Yeah, fluoroscopy. Shots.
The videos.
They are pretty good. They are remarkable.
So, what can we be educated on for the Cincinnati pre-hospital stroke scale?
So, we've standardized on the Cincinnati pre-hospital stroke scale. So we're talking about facial droop, asymmetric smile as one item. We're looking at arm drift. And we're also talking about speech. So slurred speech, difficulty pronouncing or understanding speech, or completely mute. If one of those is positive, it's a 72% chance that they're having an acute stroke or a stroke. And these are going to be new findings. So if I've already had a stroke, I've already got baseline right-sided facial droop. Deficit, then that doesn't count. But if they've got 3 or more three signs, that's going to be an 85%. So it's pretty good of detecting these strokes.
Pretty sensitive,
And it's so quickly done.
Oh, yeah.
And so once I have a positive there, am I done?
You're not. I know. So Cincinnati should be done as part of your initial assessment inside the house.
scene, yep.
And that's going to key you up to like, oh, there's Cincinnati positive, it's stroke. We got to kind of move. Time is of the essence. Ideally less than 15 minutes in the house. We're going to package that patient up, maybe give a quick phone call to your local ER to let them know that you're on your way in.
Cincinnati positive stroke.
Cincinnati
Hey,
positive
coming to
stroke.
you with this.
Yep. Hemodynamically
I'm
stable.
going to
Call
be
you with a bigger
conducting a
update.
van plus en route.
Yep.
Yes.
And so we move on to the van assessment while we're in your ambulance. And van's pretty easy. It's going to rely on your findings inside the Cincinnati. So if you have arm weakness, so eyes closed, palms up to the ceiling, you're going to have them count to 10 out loud. And that actually helps you do a lot of things, right? You can assess their speech by just having them do that. 'Cause
Absolutely.
They're counting out loud. And
New medics can take a breath.
Yep. And you're going to look for arm weakness, drip, those types of things. So if their palms are up and their eyes are closed, your body, if your eyes are open, your eyes and your brain can see your hands. It's going to be able to compensate for any weakness. That's why we have to close
close
the
your
eyes.
eyes.
Yep. So we close the eyes, and so that way the brain doesn't know what the arms are doing. If you have true weakness and drift, that arm's going to start to drift down on one side. Your brain's not going to know it, so it's not going to be compensating to bring it back up. Or if you've got some decreased grip strength. So at that point, we know we have arm weakness, so we have concern they could be van positive. If there's no arm weakness, you're done. You're van negative.
Yeah, very simple. Really quick exit process right there.
So now we're like, okay, we've got arm weakness. We're concerned that this could be they could be positive, and concerned for large vessel occlusion. So we're VAN stands for vision, aphasia, and neglect, essentially. So for our vision, we're going to ask them if they've had new onset of blindness, if they got a visual field defect, or double vision. If they say yes, you're done. They're VAN positive. They have a vision issue. They're VAN positive. No need to stop and go collect your $200. You're VAN positive. You can assess their vision, and you want to look in all four quadrants of each eye and make sure they can see your fingers in all the eyes. Oh yeah, that looks blurry, or oh no, that I can't see at all in there. And what you can do is you can come in from the side to see how blind they are. So that's vision. Aphasia. So we've got 3 different types: expressive, receptive, and global. And aphasia is just the fancy doctor word for can't speak.
Doctor word.
We are so totally making that a short.
We need
fancy
shirts.
doctor
We need
word.
shirts. Doctor words.
Prehospital Paradigm Podcast. We use doctor words.
If you don't, I am.
Put it on our grab bags.
There it is. There it is.
Got doctor word?
Got doctor word. There it is. Yeah.
So we've got expressive aphasia, and essentially they're having difficulty either picking a word or coming up with a word. So it's speech. Expressive aphasia just means speech. Receptive aphasia means that they can't hear you so well. Their reception is not working. They can't understand you. And then global aphasia is just both don't work. Right. Essentially, it's really kind of simple. So. The hardest thing I think about this, and definitely better if you have family member there, or even sometimes that's the patient, is are the patients slurring their words, especially if you don't know them, right? Because they could just slur their words, and that could be a baseline, or it could be from a prior stroke, or hey, does your voice sound like your normal voice? Or family goes, is this their normal voice? Yes or no?
Yeah, I mean, my father-in-law is saying, his baseline speech was hard to understand, right? And if somebody, if a provider had come up on him,
never met him,
they would be looking like, no, that's okay.
well, or we have that other thing too, where it's like we talk about blood sugar. I actually had one of our squads call me and interact with a patient, like slurring the words, and they're talking to him, but the patient, and it was an elderly woman. She was making perfect sense, A&O times work and answer all questions, no arm drift, and they're like, we're just not understand where you're getting your slurred speech from a little bit. She was a little, garbled, and it happened to be some vodka. So I mean, she was
had 4 fingers before you showed up.
She said it. She's like, I have some
We
of these
call
before
that-
I go to bed. Helps me sleep. So we have to do a full
That's called
assessment.
Vacasia.
Just throwing it out there. You never know. Maybe a little alcohol on board.
Yeah, absolutely. You can have 2 things true at the same time. And then neglect is an interesting finding when you see it. For eyes, they're going to have forced gaze to one side. They're going to actually be ignoring one of their whole sides. For bad neglect, you can actually ask them, if I was having a stroke and you asked me, and if I'm looking at Scott, I would say I could see 2 people because I can see Scott and Caleb, and I don't even know Ray's here.
Ray's there, right?
So it's pretty profound and interesting finding, and not great for the patient, but definitely an interesting physical exam finding. So, anyways, if their vision is impaired in any way, they've got any sort of aphasia, or they have neglect, which is super bad, they're vein positive, and raises our concern that they're going to have a large vessel occlusion. And the whole reason why we care about that is if they do have a large vessel occlusion and they're within the thrombolytic window, they're going to get their thrombolytic because that's the primary treatment for that. But it also opens up the ability of going for a thrombectomy. And Ray talked about those thrombectomy available, capable facilities, and then the comprehensive facilities can do it as well. But we have now, instead of the shortened time frame of a few hours to give the thrombolytics, we're now up to 24. So those wake-up strokes that we don't know, they went to bed normal at 9 o'clock, it's now 6. We can now possibly get them through to thrombectomy, go in there, mechanically pull out a clot, just like we do with heart attack and STEMIs, right? We go in there through the vessels, we just pull the clot out to then restore blood flow to the brain.
Yeah, that's why that CTA is so important, right?
Correct.
So they can, the hospital's going to do that non-contrast head CT, and if it's a large vessel, they can immediately follow up with a CTA and know exactly where that vessel is going to be blocked. So if you have to go to the mechanical thrombectomy point, then you're going to transfer to the thrombectomy capable hospital or comprehensive. They go in and remove that clot, and now it opens up such a larger window for those stroke patients to have that portion of the brain be reperfused. As
Correct.
before, it was, well, you're past the window. I can't give you that thrombolytic,
Yep.
right? I'm out of my time window, and then our options decrease. And Caleb, you talked about long term. Well, long term choices aren't very very good at that point.
Right.
Then they're just, this adds such another option for our patients.
Right.
All right, so the harder question here is, now that we're arming ourselves with all this information, equidistant between a comprehensive and a primary stroke center of a VAN positive patient.
Comprehensive.
It's a no-brainer, right? I mean, you're going to go
100%.
comprehensive. So you're not equidistant between them. What are our trigger points to accept a little bit extended transport time to get them to a comprehensive? What things clinically should we be focused on to say this patient is better suited for comprehensive, even though I'm going 8 more miles, 10 more miles, something like that?
I'll make it really easy for you. If it was your family member, what would you want to do?
Advocacy,
Yeah.
100%.
If this was your family member, if you wanted the best outcome for them, if this was, we were transporting Caleb's mom or having a stroke, where would we want to take our own loved one? Take them to that place. Even if it's going to be 8 months more down the road. That's the best and right thing to do.
Yeah.
Okay. And in that same vein, what about timing? Let's say we're way into the stroke. It was a wake-up stroke, last known well. Big question mark, right?
Sure.
Is that patient better suited for the comprehensive, or is that patient better suited for the primary?
I would probably say they're actually more better suited to go to a comprehensive stroke center. And the reason for that is if you bring a patient within the window for thrombolytics, we can give that thrombolytic early.
Yep.
That I can absolutely do. And then we have 24 hours to go for to go and pull that clot out. However, a patient that's outside those few hours of windows for get the TNK, their only hope is thrombectomy. Their only hope is to go in there and be able to pull it out. So if it's going to take a little bit longer time, you spend the extra time.
Get them there because they have a bigger bag of tricks for all intents and
yeah.
purposes, right?
Yeah, they get those resources.
We got more plays. Yeah.
Yep. And on top of just the van at UH, we added what we call the Van Plus. So we talk about the van assessment and vision, aphasia and neglect. But we added concern for like posterior strokes.
Yep.
So we added on the 2 extra that we pulled from the men that we also do in the hospital. And that's just finger to nose and heel to shin. So yeah. Just a touch
And why? Why did we add that? Why is it important?
Can I answer that? Am I
Yeah,
allowed to
please.
chime in? Sorry, this is like another word. This is like my penumbra
That-
word, right?
that's your trigger?
Sorry, this is my trigger. I'm the plus part of that, obviously. So, like, I have a story with this, but I was actually one of the ones that was very verbal with Dr. Spanner, our stroke coordinators, Erica at Portage, her and I work closely together, and all the physicians. And because when we used to teach MEND, it was like we always used to say, hey, this is a 12 lead for the brain, right? I'm going to understand, is this a left brain stroke? Is it a right brain stroke? And when you do the Cincinnati and you're going to do the van assessment, right? So we're looking for that high percentage stroke I'm going to catch with the Cincinnati. Then I dump into a van. I'm going to see, is this a large vessel? We really don't catch posterior strokes. It's one of the highest missed. So we're worried about that cerebellum in the back. So finger to nose, heel to shin is going to be our coordination. And these could be some subtle hints from patients. Maybe they have an unsteady gait. It just might be very, very broad terms.
Ataxia,
Yeah, and it
subtle things.
And I actually have a personal call I was on myself, and it was 3 a.m. And it was a gentleman he called, and I think he was 48 or 52 years old, and he just had like weird symptoms. Got up to go to the restroom, and he's just like, I'm just like uncoordinated. It doesn't make sense. And we're running through all of our, I'm ruling things out. Sugar's fine. Passes the Cincinnati stroke scale. I'm like, well, you've been drinking. Do you have any medical problems? And I'm just not lining up. And I did a Cincinnati. We were doing MEND at the time. And he's passing everything.
Everything on the Cincinnati.
And I get down to finger to nose and heel to shin. They're the last 2, and he fails it. And he's totally alert and oriented. He knows what's going on. But now he's like, what the hell is wrong? Like, I can't do this.
Right.
What am I missing here? What's wrong with me? You obviously know what you're doing. And, it's kind of hard to explain to patients, hey, we got to do a bunch of funny tests on you and move down this pathway. And you get to the end of it, and now they fail it. And you're like, oh, I found the golden goose here.
Yeah.
This is a posterior stroke. And I did follow up and confirmed it was a posterior cerebral stroke. But we don't want to miss those. Well, it's just, it was one of those things, you're like, deep down, we're all like, oh, I called at 3 a.m. This doesn't make sense. And I'm heading down this pathway. I can't find anything wrong with him. And I had to get all the way to the end of that whole thing.
That's why you don't
to be able to
vary
figure
from
it
that.
out. No, it's very important, and I was very pro pulling that from the MEND. Our medical directors all of us were as educators, because we don't want to miss that. It's so easily missed. And, we want to take that patient to the right place, get a, non-contrast CT and, or maybe a CTA to see what we can do to help that patient. So I think it's extremely important to do that. A lot of people blow it off and do it wrong too.
Right.
So
Well,
I'm on my soapbox, and I'm sorry.
No,
but,
you're talking about the subtleties of stroke here.
Yeah,
and
like
that's really what the posterior is. It's often subtleties.
100%. And a lot of them are, okay, touch
No.
my take your finger, touch my nose, touch my finger. No, you want extension out there, because a lot of times
reach, right.
you get as soon as we start to get out further, we lose it. It's just like when we're testing for vision, in the van, it's that peripheral vision that's lost during that stroke. So we want to catch those subtleties and pick up on that so that we don't miss that stroke. And that could be a huge difference in that patient's outcome for treatment, and then, longevity of life and their ability to function. So it's my pet peeve. I'm sorry. That's my soapbox.
That's a good
I
pet peeve.
apologize.
No,
Yeah.
absolutely. That's a very pro-patient pet peeve. Yeah.
Well, and to the point, like if you don't know what's going on, why not run through all your bag of tricks?
Yeah.
Why not just do a quick neuro assessment? It takes a few minutes.
yeah, cast a wide net.
Yeah, exactly. So
You can always reel it in.
This doesn't make sense for a guy. Let me just do a quick neuro assessment on you. When I ask A&O questions, hey, I got some funny questions for you. What's your name?
Yeah.
And we go through this thing. And then you might say, okay, what year is it? And that's 1964.
Neat.
Cool. Well, then.
This might mean something.
And with, especially with the finger extension, the nose to finger, as you said, full extension, because it's going to get more pronounced
Yes.
the further you go out. And it's more important to test cross body. So you can go same side, but you should get more when it goes across because now we got to have communication between both sides of the brain to understand that. So it's more important to go.
Yeah, that's a good point. Yeah, really good.
To make sure you come across, and that's the whole point of heel to shin, right? You're not doing it on the same leg. You'd have a broken leg if you did. But you're going across the midline, so your body has to coordinate both sides of the body, and that's where it comes out.
Probably the hardest one to describe to a patient, though, right?
Yeah,
I mean,
it is.
Scratch your left shin essentially with your, your right heel, or move it up and down.
I literally just grab their pant and I put it. I need you to do this. Now you do. Now you do this, right?
It's called battery.
I give them some Versa, and then I say, do this.
We've talked a lot about diagnostic tools now. So, how many of these stroke centers are there? Comprehensive? How many primary? Are we flooded with these? Saturated?
You're pretty saturated with your primary stroke centers. As I said, there's 57 as a recording of this. There are 17 of the acute stroke ready that can accept them. And then we get really limited in our thrombectomy and our comprehensive, which can do thrombectomy as well. But there's only 5 thrombectomy here in Ohio, and then 13 comprehensive. The good news is those numbers have increased in recent years. We've got more available, but for the most part, your local community hospital is going to be your comprehensive, and your big tertiary centers or your level 1 trauma centers or your big city ones are going to be the more comprehensive that have all of the stuff. And really the big thing is making sure that in the comprehensive, we want to make sure we've got neuroinvasive to go out and do the thrombectomy, and we need neurosurgery. And that's because with giving the thrombolytic, as you can imagine, we're breaking down clots. You can't make clots. You then can bleed. And that's what we're checking for on the hospital side, that we're going to be doing multiple CAT scans on you.
Right.
Because just to make sure you're not having a massive bleed. With our strokes, whether you get TPA or not, we're going to expect a little bit of what we call hemorrhagic conversion. So on the next day, we're going to expect to see small petechiae bleeding inside the brain. That's totally normal after a stroke. We just don't want to have massive bleeding inside the brain that's going to cause increasing pressures and shift, and that's the badness that those patients then go from the primary care center to a comprehensive center because they might need literally a hole in their head to drain out that blood. They need the bigger stuff to manage those.
And I don't know if I think we danced around this point, is that comprehensive stroke center has that neurosurgical intervention 24/7,
Yes.
right?
Yes.
And you mentioned a little bit ago about thrombectomy capable hospitals, and in those cases, you kind of need to know that. I don't think that was on your list, right? Because I believe that's fairly loose vernacular, right? And mostly
I believe
local.
so.
Yeah. So
It's not
looking at
super
the
well
list,
defined, right?
well, not well defined that I could find, but one of those thrombectomy capable centers is where I trained, and we had neurosurgery available 24 hours a day. So
Right.
they may not be able to check all the boxes to get to that, but again, like you said, the trauma center level is a great example because you've got 4s, which are your
Stroke
your
readies.
stroke readies. They can take you and manage you initially in the emergency department because the emergency doctors are fantastic and we're great at all the things that we do. We're very good general emergency medicine. We're experts in resuscitation. We're experts in airways. But I say that we're kind of number 2 at everything. We're the second best cardiologist. We're the second best OB. We're the second best
There's a lot
gynecologist.
of truth to that, yeah.
Yeah. Because we do outside of the specialists, it's us.
Right.
It's just a wide variety.
It's a wide variety.
You never know what's coming.
The point I wanted to make about the thrombectomy capable facilities is, you kind of have to know in your local area, since they're not really on registries anywhere, right? They're going to show up as a primary stroke center, but they may have these other advanced interventions. But that makes it even more important for you to make that early call. So if they have to call that team in, or if they have to, clear a suite out to, because it's probably a suite they're using for something else as well, right? It's a multi-purpose suite. So if you have to clear it out for this incoming stroke, it's even more important. So you have to know your local resources,
100%.
and of course make that call earlier, so they can mobilize those teams if it's not a 24/7
Yeah, that's a good point.
facility.
Yep.
you made a comment a little bit ago about the stroke screenings, whichever we're doing, being the 12 lead of the brain, and there's a point I wanted to make. Often forgot in an obvious stroke is to do a 12 lead, right?
Yes.
And my sales pitch, and we were talking about this earlier, is there's never just one clot, right? So it's going to go only a couple of places. It's going to go to the heart, it's going to go to the brain, or it's going to be an arterial occlusion out in the periphery somewhere. One's easy to see, the other two you got to go look for, right? And you're going to do that with your 12 lead as well as your stroke screen. But there's this, I've come across providers like, well, I know it's a stroke, so what do I need a 12 lead for? Well, you don't know that it's not a stroke and also a STEMI, right?
Correct.
And so very important part. But once you have them loaded in the truck, you're moving to your stroke center. Vascular access. We talked about stroke mimickers already. And then, of course, get a good 12 lead EKG and get that sent along as well.
Yep. Yeah, the patient could be having both, Scott. And Caleb and I were talking about a local case here that came to one of our emergency rooms where the patient was having a stroke, obvious signs and symptoms. Squad did a good job with the 12 lead EKG on. And, they're having a STEMI, and that's going to be really important to relay to the facility. And they sent the 12 lead to the physician, and then they called back and said, "Hey, well, we're bringing you a stroke and the STEMI." And we're like, "Yeah, we got the 12 lead. Is this two different patients or the same one?" Right?
Please tell me this is two different patients.
It's a fair question. No, it's the same one. You get all in one deal, and then that changes the game because we talk about Brilinta and heparin, which has kind of been a hot topic lately. That's not something we're not going to be able to tunnel down that road and treat this STEMI now. I don't want to give them aspirin. I don't want to give them Brilinta, heparin, nitro. I don't want to do any of that because I have both of these items going on at once,
And there's one great treatment option here right now, and let's phone a doc. Hey, med control.
Yeah, 100%. Communicate.
Yeah. But then it's also important, you bring up a good point, that we need to know that we're taking them to the correct facility for sure. I mean, it has to also probably be cath lab capable now too. So it's we had a trauma incident a couple months back. MVC was a trauma patient, but again, it was which came first, the chicken or the egg, because this patient may have had a stroke that caused the incident. And again, it might not just be STEMI; it could be trauma, it could be a lot of other things.
Yeah, and you don't want to give a stroke patient that was in a trauma thrombolytics.
Right.
Sounds like a bad combination.
All right, so we've covered a lot today talking about strokes. We've talked about the receiving centers at different levels, whether they're stroke ready or they're comprehensive, primary. So I think that's some of the takeaway points here that we'd like to wrap up with is know your local stroke centers, know what their capabilities are.
Absolutely.
When EMS arrives, I think we have to really get a full story that we're able to pass on.
Yep.
And, something we covered early on was we might be one of the very few people that are able to obtain that true story and then pass it on again. To Caleb's point, when we're assessing that patient, it's going to be vital information to give to the ER physician. Know your stroke assessments. We want to be proactive with a Cincinnati early in the house. We want to kind of rule out some of those stroke mimics. We want to obtain a blood sugar, do a follow-up. We want to hit the VAN exam or the VAN plus, vision, aphasia, neglect, and then we want finger to nose, heel to shin to try to check for that posterior stroke so we don't miss that. And, some of the other points with transporting our patients are going to be, don't overload them with oxygen if they don't need it, right? We discussed that.
Transport them with their head up. Yep.
Yeah, transport them with their head up because, they're losing they might lose somewhat of a gag reflex or control of their tongue. We don't want them to vomit, aspirate, anything like that.
We don't want to lay them back, increase intracranial pressure.
100%. So
Keep
I think
PO. Don't let them eat a hamburger on the way to the hospital.
Don't stop at McDonald's. Yep.
So I mean, those are, I think, some of the big points that we talked about. We talked about TPA versus TNK and the thrombolytics use. Some of the imagery that happens at the hospital where we're doing a non-contrast head CT versus a CTA, and it's all about time, right? It's about how can we compress the time but get everything that we need and get everything we need done for the patient and get the patient to the right place. So I think that's
smooth transitions of the baton from each step.
100%. Yeah, with clear communication, passing that message on and just high quality patient care.
Cincinnati on scene. Van. Once you're rolling.
Yep.
Get a line. Certainly glucose. Rule out. That is the most common stroke mimicker.
EKG.
And get your EKG, right? Get your 12. Get your 12.
And blood work if you can.
Blood work if you can, right? If you have the tubes on the non-expired tubes on the truck.
And try to get at least a 20 gauge angiocath, and the anacutals are up.
Good size IV for your contrast if you need it at the hospital.
And make sure we're totally okay with hypertension. In fact, if you think this is a stroke and they're hypertensive, that's going to give you more information to make you think that they actually are having a stroke. And we're okay with those high blood pressures.
Don't mess with the blood pressure.
Correct. Yeah. Let the body compensate for what it needs to do. I think a lot of times in medicine, especially people new to medicine, think that I'm going to go in and I'm going to be able to help people because I'm smart and I know what to do. Really what medicine is supporting the patient.
Correct.
If they need antibiotics, get antibiotics. If you need thrombolytic, giving them that thrombolytic. If it just means blood pressure control, we're controlling the blood pressure. We're kind of helping the body heal itself. We're not smart enough or have the capabilities to go in there and fix the body for itself. The body needs to repair itself. The body knows what it's doing and just let it be.
Body's smarter than we are.
It totally is.
It's way smarter than we are.
Yep.
All right, guys. Well, it's been a great talk, and it's good getting back here in the studio and recording this, and little bonus material for the fifth week
100%
of fifth week of May, right? So we thank you for tuning in, and like us on Facebook and subscribe on YouTube, and that's where you'll find us at EMSI in both places, on Facebook and YouTube, and we'll catch you next time.
Yep. Additionally, we have our website too. So
yes,
prehospitalparadigm.com. Check out the show notes there.
Shameless plug to send us some email of questions you may have, any topic clinically related, that you can throw in our mail grab bag. And we were actually talking about doing one of these bonus shows later in the month, or later in the year, because there's 3 months this year that there's five Mondays. We're talking about doing a grab bag episode. If you can send us some interesting questions and cases,
we'll send you some swag.
And we'll send you some swag. We'll be looking for it. So.
Hashtag Dr. Word.
Doctor word. Only thing they're going to remember out of this entire episode. So. All right, everybody. Take care.
Happy Memorial Day.
Thank you.
Yeah, happy Memorial Day. Yeah, this is Memorial Day.
Yeah, that's crazy.